Hello, everyone, and welcome to this webinar on HPV vaccine delivery. Mobilize, Deliver, and Sustain, Lessons Learned and Practical Advice for Effective HPV Vaccine Delivery in Low and Middle Income Countries. Thank you all for joining us today. We have the pleasure of having three excellent speakers here with us to be able to review some common lessons learned from HPV vaccine delivery in low-resource settings. How the webinar will go today is we'll make a small introduction to our panelists as well as to the webinar content. The panelists will give their presentations, and then we'll have a question and answer session afterwards. For questions and answers throughout, you can use the chat feature on the webinar interface to submit your questions online, and we encourage you to do that throughout the speakers' presentations as questions come to your mind. We will be organizing those in order for us to have a rich discussion at the end of the presentations. The way the webinar will run today is we will be reviewing lessons from a research project that was conducted by PATH and the London School of Hygiene and Tropical Medicine that looked at different themes and different lessons from HPV vaccine delivery, both from countries that ran small pilots or demonstration programs, as well as from countries that have introduced the vaccine nationally. Because the data are very rich and there's lots of material, we won't be presenting every finding from this work, but rather focusing on some specific areas where we have found over the years the most common concerns and questions related to effective mobilization, efficient delivery, challenges and pitfalls, and how to build sustainable models for delivery. We are also lucky to be able to have representatives here who have been working intimately with countries, and they will bring their stories from the field to bear in our webinar today. So let me introduce our panelists. Dr. Debbie Watson-Jones is an epidemiologist and faculty member at the London School of Hygiene and Tropical Medicine in the Department of Clinical Research and was the principal investigator for this work. We're joined by Kate Gallagher, who is also in the Department of Clinical Research at the London School of Hygiene and Tropical Medicine and was one of our co-investigators in this study. Our third panelist is Dr. Carol Tevye-Benison. She is the New Vaccines Introductions Medical Officer for the World Health Organization's Regional Office for Africa, based in Brazzaville. And then I am Scott LaMontagne. I'm the Director for HPV Vaccines at PATH. To review the study objectives, we had three primary objectives for this work. The first is to collate and synthesize all of the available lessons that we could find related to HPV vaccine delivery, either in a demonstration program or through a national introduction. We wanted to generate recommendations from these lessons that could be applied successfully to give advice to others on how to introduce the vaccine. And finally, we wanted to use creative mechanisms to disseminate this information. This webinar today is actually one of those creative mechanisms. The study method included 46 countries. We had 18 countries that were classified by the World Bank as low income, 22 as lower middle income, 5 that were upper middle income, and 1 high income country. From across these countries, we tried to systematically collect data through 3 viable means. The first was a systematic review of the published literature, where we looked at any study that had been published that described the experience of actual vaccine delivery and the evaluation of that delivery. The second means of data collection was to then collate other reports or literature that were available. These were largely technical reports either from the countries that implemented the programs or partners that helped them with the implementation. And these two pieces of data were complemented by key informant interviews of 56 different representatives across 40 of the 46 countries. From all of the data collected in published and unpublished reports and through the interviews, we extracted information that would be informative for new vaccine introductions for HPV. And there are guidelines from the World Health Organization that give advice to countries about the different components of vaccine delivery that they need to plan and prepare for. We collated the data on themes to look at what were the lessons for preparation, for communications and social mobilization, for vaccine delivery itself, what kind of achievement was done through the program in terms of coverage, what were the factors that contributed to whether these programs could be sustainable, the value that the countries received from doing demonstration programs, and what are the common pitfalls or challenges to avoid. Our research was approved by the Ethics Committee at the London School of Hygiene and Tropical Medicine. Included in our study, as I mentioned, was 46 different countries, and this figure on this slide gives a breakout of how those countries contributed to this research. You'll note on the purple bar that there are countries that contributed because they implemented demonstration programs, and other countries had implemented national programs, either with or without having a demonstration program experience prior to national. If you add these up, many countries implemented more than one program, either more than one demonstration program and then went to national, or more than one pilot in and of themselves. We wanted to understand if there was any differences in the types of programs that were being implemented, so we counted each one differently. We call these distinct delivery experiences, and they're defined by the venue of vaccination, the target population that was done within the program, and the funding source. Some countries did different programs for HPV vaccine delivery in different parts of the country, funded by different agencies and run by different organizations. Each one of those programs was counted separately, even though the country was counted once. So overall, we have 92 different distinct delivery experiences that are a part of this project. They represent in total over 100 years of vaccine delivery experience, reaching almost 2 million girls and vaccinating nearly 1.5 million. So I have the pleasure to be able to introduce our speakers who will run through the findings from this work. They will summarize the lessons learned for communications and social mobilization, for delivery, for sustainability, and the pitfalls and challenges to avoid. With us then is the principal investigator, Dr. Debbie Watson-Jones, and the co-investigator, Kate Gallagher, who will take us through the findings from the research. We'll first start with Kate, who will cover communications and delivery. And then after Kate speaks, we'll hear from Dr. Debbie Watson-Jones, who will take us through the aspects of the programs that were common for sustainability and the common challenges as well that countries faced in which we want to avoid. Kate, I hand it over to you.
Thanks, Scott. So, next slide, please. So let's go ahead and I'm going to describe what country representatives have told us works in communication and how to mobilize communities. All countries reported an overall low level of knowledge and awareness around HPV vaccine and related diseases, and this was both in the general community and among health workers and teachers. So this meant that specific training of health workers, teachers, and community leaders was necessary in order that these members of society can then go on and deliver accurate messages about the vaccine to the community. The majority of countries used a cascade model of training for the health workers, And this was where the national team trained the regional team, who then trained the district, who then went on to train the frontline workers. Many reported that this was successful and that just a day was sufficient. However, some level of supervision was needed to ensure that the same information was transferred to all participants who attended training. And where training fell down, or where there was a pitfall, was where, for some reason or other, health workers didn't ever receive adequate education themselves, and therefore this affected social mobilization. The key messages necessary to deliver to the community were remarkably consistent across countries and regions, and included a focus on the anti-cancer properties of the vaccine, rather than prevention of HPV. They also focused on the fact that the vaccine is safe, and specifically will not harm fertility. There were messages around government endorsement, and that other countries have similar programs running. Social mobilization was effective when interactive methods were used, for example, face-to-face meetings at the community or community sites, rather than non-interactive posters and leaflets. Credible influencers were also important, and these were identified as health workers, teachers, or community leaders. A number of countries also stated that social mobilization could decrease after the first year or two of national programs, and that demand remained high. Next slide. We collated a vast amount of data on acceptability and consent processes from anecdotal reports, written documents, data sets, and specific acceptability surveys. Overall, despite this low awareness of HPV and related disease, acceptability was very high. And I will show you coverage achievements for the vaccination programs in a few slides' time. The top 3 reasons parents cited for accepting the vaccine in 12 parental surveys included that the vaccine or vaccines in general are good for health, and their desire to protect their daughter from disease or infection. The reasons cited for daughters not receiving the vaccine were logistical, that they'd not been aware of the program, that their daughter was absent from school, or that some parents were fearful of adverse effects, and this again was limited largely to effects on fertility. Reasons for non-completion were similar to non-vaccination, with the addition that there were issues where, in demonstration projects, where girls migrated between areas, between doses, or transferred between schools. There were some groups of people who refused, or institutions, and these included private schools particularly, religious groups, or anti-vaccine groups. And the lesson from that was that these groups require more intensive mobilization, more information, more frequently, with targeted messages and engagement of key stakeholders within their community, for example, religious leaders or head teachers. Health worker hesitancy to recommend the vaccine did contribute to refusals in a few countries and led to some suspicion within the community. But the lesson from this is that ideally, health workers who may be approached by parents for advice but are not necessarily the vaccinators could also be educated at some point in the program's lifespan. Consent processes were mixed. Some countries requested full written consent from parents before vaccination, and this could be by sending the form home with the child and asking them to bring it back into school with them, or at parent-teacher meetings, or parents attending the vaccination day themselves. This is what we call opt-in consent on the slide. The remainder of countries used opt-out consent. They mobilized parents and supplied information, and then asked parents to keep their daughter home or tell a teacher on vaccination day that they did not want the vaccine. Generally, if opt-in consent was used for HPV vaccine where it was not the norm in the national immunization program, this stimulated suspicion within the community and lowered acceptability of the vaccine. This was particularly reported by 7 countries who ended up changing to opt-out consent. Next slide, please. The timing of social mobilization depended on a number of processes occurring and needed to occur well before vaccination day. Delays could result from delays in disbursement of funds, the development of training materials or communication materials, and when delays occurred, social mobilization was often conducted late, and this caused problems and delayed vaccination. Private schools often needed more time, and this was often underestimated in the first year of the program. And as I've said, they often needed a higher level of information and sometimes generated their own consent procedures. Exposure to negative media was occasionally underestimated as in its impact on coverage achievements, and really needed to be planned for right from the beginning. Rumours were generally consistent across the 46 countries that we looked at, and there were, and as I've said, they were generally focused on the alleged effects of the vaccine on fertility. The impact of rumours was mitigated by rapid, tailored communication messages, including endorsements from government officials and dissemination of the WHO safety statements. However, despite rapid responses, some countries did find it difficult to recover from rumours, and the lesson is really to prepare and plan in advance and in order to prevent rumours gaining speed in the first place. Next slide. So I'll go through a similar rapid set of lessons around how to deliver and the experience to date in delivery. Next slide. So the vast majority of experience to date is in school-based delivery. This has proven to gain good coverage, but is reported as resource intensive. In school delivery, when you have a mixture of ages in each grade, the implementation of grade-based eligibility criteria was generally logistically easier and quicker. However, it could cause some issues in communication, especially if you have an age-based criteria for out-of-school girls. Some countries did test joint delivery where they integrated another service with HPV vaccine, and generally these interventions were deworming, pills, or tetanus toxoid vaccine. One country did integrate HPV vaccine with a hepatitis B campaign, but there were few other interventions tested. Prior to delivery, enumerating the target population was challenging in all countries, and generally headcounts proved to be the only way of estimating an accurate population number. This may be less of a problem in national programs where census estimates could prove more useful, although one country stated they had to conduct headcounts anyway in order to plan vaccine distribution. And there was a real uncertainty as to how to deliver 3 doses to HIV-positive girls. Countries need to be aware that HIV-positive girls still require 3 doses, but the dosing schedule can be flexible. They could receive the 3rd dose at 18 months or be invited to the health facility for an extra visit in between the 1st and 2nd dose. Next slide. Uptake and coverage rates were really very high across countries. Demonstration projects and national programs both achieved very encouraging rates of coverage. Over 80% of our estimates we collected demonstrated over 70% coverage. And as described, most of this is in school-based strategies. We collected only 5 estimates from health facility strategies. As you can see in the graph, where the boxes outline the interquartile range and the line through the middle of each box represents the median value, the 3-dose and 2-dose schedules attained similar high uptake, completion, and coverage rates. This graph includes 10 estimates from 2-dose schedules. Registers and cards helped to track girls with incomplete schedules and also aided the vaccine coverage calculations. Next slide, please. So we only had 9 coverage estimates from national programs, but they were high and exhibited a similar average to the demonstration projects. Next slide. Factors correlated with high coverage experiences included strategies using schools, but where there was also a good collaboration between health and education sectors at both the national and local levels. We had limited data on the health facility-only strategies, as I've said. Involvement of national immunization programs in planning and implementation was important, and occasionally the reproductive health or non-communicable disease departments led the program, and it was clear that strong involvement from the national immunization program remained to be a factor key to success. Targeted social mobilization of out-of-school girls was the only demonstrated way to achieve any uptake in this group. Assuming girls would come to the health facility without targeted messages led to low uptake. As we talked about, comprehensive social mobilization of the community, including the use of credible influencers, is important, and delivering vaccine on schedule and within 1 school year. Factors correlated with experiences that gained low coverage, and here by low coverage we mean between 50 and 70% coverage, demonstrated ineffective coordination and planning with schools, suffered from rumors that caused whole schools or large groups of the population to refuse vaccinators. Urban areas were more likely to achieve lower coverage than rural areas, and this was generally thought to be due to a higher exposure to negative media or mobile populations. And other factors included some delays in social mobilization or not providing a second opportunity for girls who missed the first dose. So I will now hand over to Debbie to take you through sustainability and pitfalls.
So thank you very much, Kate. So I'm now going to take you through some issues that affected countries' views of how they would move forward on HPV vaccination, and then look at some of the challenges that were common, I think, across many of the projects and demonstration programs. So if we can go to the next slide. First of all, looking a little bit more now at the financing and cost of the programs. We had 66 demonstration projects in 44 countries that received vaccine and or support for financially providing some initiatives to deliver the vaccine. We had funding from GAP that provided vaccine support, Gavi that provided vaccine support and some funding to deliver the vaccine, programs from PATH, from ACCF and from other sources. Basically, there was also some funding from national governments, and what the findings showed is that for a current financial cost per dose, the costs ranged in the initial demonstration projects and the Gardasil Access or GAP program demonstration costs between about $1 to $2.7 per dose. We had data from only 5 Gavi projects, but there are some indications that these projects were slightly more expensive, with a cost per dose of about $3 to $9. So this may be because funding was provided to deliver the vaccine, and that it may be that therefore there was perhaps less motivation to really look at the costs of delivery, or less issues around accountability because national funding was being used to deliver the vaccine that might have happened in the other programs. The reported cost drivers for the demonstration projects included staff and supervisor transport. This was particularly important for outreach and school activities, the associated per diems for that time, social mobilization activities, and particularly also enumeration activities. There was some evidence from the limited data we had from national programs that the cost of delivery in national programs would probably be lower than for demonstration projects, coming in at around $2 per dose. But the real issue here is that for countries who are not able to have Gavi support or are graduating from Gavi, and I'll come on to that now, vaccine delivery at this sort of level may remain potentially unaffordable for these countries. So as many people will know, if countries' economies start to grow and go above about $1,580 gross national income per capita, these countries have to graduate from Gavi support. And they therefore have to commit to gradual increases in co-financing of the vaccines over time. And this was reported to us as a significant barrier to introducing the vaccines at national level. So if I can now go to the next slide. If we now look a bit more at the barriers to scale up, we had 11 out of 24 countries with demonstration experience who stated that they were not going to scale up. There were a number of reasons for this. There was uncertainty about the future financing and the ongoing political commitment. And this was largely due to the perceived expense of the school-based delivery strategy and uncertainty over the future costs for the vaccine. As mentioned in the previous slide, ineligibility for Gavi support was a major barrier for some of these countries. In terms of paths to scale up, we have 13 out of 24 countries with demonstration experience who did plan to scale up. And of these, just over half preferred to look at a phased scale-up approach, so not to launch nationally in the whole country at the same time, but to roll this out perhaps over regions or districts. What was also clear was that these scale-up countries were going to seek to acquire additional funding from partners for specific activities. Funding was a major theme here, and one of the activities that they felt might be important to get specific partner funding from was for social mobilization. They also explored the possibility of looking at more routine delivery strategies, for example, nesting the vaccine in routine services in health facilities, and to obtain more technical advice to fill capacity gaps, particularly in areas around budgeting and forecasting. Of note, 2 countries looked at longer-term plans for sustainable financing of EPI with commodity taxes. One was exploring the use of a tobacco tax, and another using a ring-fenced EPI budget through an immunization law. Next slide. So when thinking about how to sustain these programs, there were a number of areas that we needed to consider. The first was the limitations in usefulness of the demonstration projects themselves. Many countries appreciated the opportunity to learn by doing with these demonstration projects. But it is important to note that a number of countries have done more than one demonstration project and yet have not committed to scale up. In terms of the limitations of the demonstration projects themselves, there were a number of missed opportunities here. District selection for the demonstration projects was often not nationally representative. Some countries selected easy areas to start their demonstration project, or cities with good performance or districts with good performance in EPI programs, and did not use the opportunity to look at more challenging settings in the country and to learn lessons from that, ready to prepare for national scale-up. A second limitation related to the small scale of demonstration projects. These were often intensive and very focused in one area, but they prevented assessment of the impact on cold chain, and they did create challenges in being able to integrate with routine programs, and often did not assess these because they were standalone projects. There were indications, however, that the national programs would be cheaper to deliver than with a lower cost per dose than during a demonstration project, and that is because it's a wider scale of economy, and demonstration projects were often very focused and had to put in special services to deliver themselves. Phased national introductions may in fact maintain political will and funding commitments at a greater level than repeated demonstration projects. There was a perception that there could be fatigue here. If you repeatedly test something but don't actually take it to national, then you may lose political will to deliver these vaccines. And one comment was that going to national roll-up or phasing in national roll-up if a country felt that they needed to learn some lessons through that approach may well help with political will. Decisions during delivery may well impact sustainability, and I think it is very important to note that many countries, I think most of these countries, had extremely good coverage. School-based delivery in these low-income settings and middle-income settings can in fact achieve as good a coverage as the most successful programs in the high-income countries such as Australia and England. And this is really commendable. We found in fact that HPV vaccine delivery is highly acceptable. Populations want this, and they can be delivered at extremely good coverage in these quite challenging settings. Some caveats, though, are that there are very limited data on other delivery strategies than school-based delivery. And as Kate has already mentioned, we did not have very many programs or projects that looked at pure health facility delivery, for example. A well-designed HPV vaccination program could be used to assess different delivery strategies, even from the start of a large program. It could explore how to achieve high coverage in challenging areas, and it could learn about integration with national systems. Innovative delivery strategies are in fact being tested in 2 countries to try and look at sustainable approaches. One country is thinking about vaccinating once a year, and another country is considering vaccinating a multi-year cohort and doing this every few years in order to get ultimately the same coverage, we hope, in those age groups, but not to have to sustain a program every year. And finally, we found that consistency with eligibility criteria and consent procedures really aided sustainability because they were easy to communicate and they reduced the rumours. Next slide. I'm now going to just run over a number of common challenges and pitfalls that countries need to try to avoid, that many countries experienced and for which we have collated the key lessons. It was very clear that where there was a lack of political commitment early in the process, there were delays later in the programme, and a number of countries experienced this. This also applied to where there was a lack of coordination with key stakeholders early on in the programme, and that included coordination with EPI and immunisation programme staff, the Ministry of Education and the Ministry of Finance. If there was failure to coordinate early enough in the programme or the project, this led to significant planning, social mobilisation and delivery challenges later on. Related to this, we found that insufficient time for planning led to very poor decision-making in certain circumstances, and very importantly, a lack of availability of funds and disbursement of these funds to the project or programme, leading to delays in all the other activities down this cascade, including social mobilisation and vaccine delivery implementation. A lesson around community mobilisation was that not engaging or trying to engage too late with the local community leaders, particularly the people that Kate has already mentioned, could derail social mobilisation, and this happened in some cases. Insufficient training of key partners such as school staff and teachers, and lack of a crisis communications plan perpetuated rumours and led to problems with coverage and acceptability. These are simple to solve, but were often neglected. Failure to engage sufficiently or early enough with private schools led to resistance by school leaders and parents. And as Kate has already mentioned, private schools were an area of challenge across many of the countries, if not most of the countries. Programs have tended to often involve just government schools for adolescent health. Private schools have often been neglected, and there is a lot of suspicion by parents towards a private school when they try to implement a government recommendation. And this really does need to be tackled as more and more private schools are opening across many of these low-income settings. There were limited focus on strategies to deliver HPV vaccine to out-of-school girls, and we saw that where that happened in those programs or projects, there was low coverage in that group. And finally, failure to correctly enumerate the target population and or to implement the eligibility criteria set at the start of the project, for example, where a project said it would target only 9-year-old girls, but in fact 10-year-old girls also came into the program or the project. This resulted in major difficulties later in accurately estimating coverage, and it also led to significant vaccine shortages and in some cases the need to procure additional vaccine. So I'm going to end the pitfalls section there and hand back to Scott, and we'll move on to the next section of the webinar.
Thank you, Debbie and Kate, for this comprehensive review of the lessons that have been learned from this important research project. And it's it's with great pleasure I have to reintroduce Carol Tevi-Benison, who's really been at the front line of new vaccine introductions writ large, but specifically for HPV vaccine in Africa these last 3.5 years. Carol's the new vaccine officer at WHO in the Afro region, and she has brought to the table with us today some interesting country examples for each of the themes that we have been presenting on: social mobilization, delivery strategies, and how to sustain these programs. Carol's going to walk us through a few of those stories from the field experience that she has been involved with. Carol, over to you.
Thank you. Thank you very much, Scott, for this introduction. I'm going to give some examples, but maybe I won't talk of all the countries, but very simple example and documented. So next slide, please. So we touched base on the social mobilization component. This is a major component on this vaccine. And what we have seen is the communication activity should target all stakeholders. I say it, all stakeholders beyond the classic target population of immunization. And we should target teachers, we should target many other stakeholders. And this communication should start several months. It's not 2 weeks before, 3 weeks before, but several months ahead. So I have a few examples here. South Africa have decided to have a school-based strategy. The only issue is during the planification, South Africa didn't train the teacher. The teachers were not involved. So during the rollout the first year in 2014, they had a national introduction with targeting 100,000 girls. And during this rollout, there was some anti-vaccine groups who just pop up, and also the teachers having not been trained, and they started sending SMS to the parents and to the girls not to get vaccinated. So the first round, the coverage was not as high as expected. So the action was that teachers had to be retrained between the 2 rounds and to get them involved, and they can help achieving the coverage. Second example is Madagascar. I think Kate touched base on that. The private school, they have to be on board. Schools, and Debbie just said that a few minutes ago, private school also should be really should be informed, and they should have more information, not only the basic one, but more information. They might ask more questions. And we found in Madagascar that the religious leaders were not really involved, and they closed the school. And there was intensive effort to reach, to inform them, and finally they accept the girls in school, in these Catholic schools, but they didn't accept the vaccination to take place in the school, but the girls had to be vaccinated outside the school. Colombia, very quickly, there was an ISI event, and because of that, this impacted the rollout of the school. And I would say that for this vaccine specifically, I think there's a need to have a crisis communication plan. Because of all this rumor, we need to have a plan in place, and the person part of the crisis communication committee, they have to come on board and take the floor and speak to the media and give very sound and evidence that the vaccine is safe. Next slide, please. Next slide. Okay. Regarding delivery strategy, I'm again going back to South Africa. We just heard that high-income countries, they can have a good school health program where they can integrate the HPV vaccine delivery. If you have a school health program which is very strong, you can add the intervention to the school health program. And this will not increase your cost because the school health program is already funded. However, in South Africa, they still have some extra expense which make the program expensive. So they decided also to co-deliver the HPV vaccine when they were giving poverty books, or they were giving information to the girls, and they link also. They are considering linking the HPV vaccine when they are giving the TT vaccine, which is also one of the integration other countries are thinking about to really integrate the two vaccines together. Regarding Tanzania, Tanzania is finalizing the second year of their demo, and during the first year they used campaign mode to deliver the vaccine in school. And they achieved high coverage, yes. However, it was expensive, as mentioned earlier, because they had to pay per diem to the health facility, health worker to go to the school and to deliver the vaccine. And many countries, at least in the region, ACO region, did the same and found themselves with high cost of delivering the vaccine. Year 2 in Tanzania, the country just decided to integrate the vaccine, the routine. Routine is already budgeted, is already funded, and there are some strategy doing the routine immunization system. And they are delivering the vaccine at the health facility, of course, and they are using the school as outreach, as they do for routine immunization. So they go to the school to deliver the vaccine, and they are using, in this case, the mixed strategy with involving the health facility and the school as an outreach activity. They also use other interventions like the warming to deliver the vaccine to the school, and this intervention was already funded. In Tanzania, they still have high cost, but less than using the campaign mode. I'm going to talk now about Chile because it's a very original and innovative schedule. Chile is the first country to use the annual vaccination schedule. We know that the position paper is recommending 2 doses with 6 months apart, but the position paper is saying the best schedule is 0 and 6 months, but you can go up to the 12 months. So this country, Chile, is giving the vaccine, the first dose at 0 months, and the second dose at 12 months for the first cohort, and is giving the first dose to the second cohort at the same moment they are giving at 12 months. So this is a good example, and it's something that many countries are starting to consider, at least in the region, to give the vaccine if they go to national introduction. Next slide, please. Finally, regarding sustainability, as David just said, is many countries are reluctant to scale up to national introduction. One of the reasons is the cost and the sustainability that they fear, and they think that the country might not be able to sustain the introduction. We have a good example of Rwanda. Rwanda has started in 2009 and have done campaign mode in school for several years, but they move after campaign mode, and I just say it's campaign mode which is really costly with this per diem and having the transport of the health worker to go to the school. Rwanda just decided to move from campaign mode to routine outreach, to routine mode. And they are using, as I say, school as outreach, and they still have a high coverage, and this reduced the cost, and they have evidence that the cost is not reduced by 80%. Although the cost is reduced, they still have some, I can say, high cost because of the outreach, but it's less than the campaign mode. Bhutan has done this introduction. They start using catch-up campaign in school. They did it several years in school. They have high coverage. However, it was still, again, expensive, and they moved to health facilities. And they are doing health facility with school. And then it was less expensive, but they didn't reach the coverage that they expected. So they went back again to school delivery. So they increased their coverage from 73% to 90%, which is perfect, which is fine. But again, as I say, to reach the program, each country has to really continue to adapt. Some countries are adapting within the country, one district to the other district. One district is doing different. One district, because of the budget they got allocated for the routine or the program, they choose one mode of delivery, and the district, the neighboring district, is choosing another delivery mode. So each program can continue to adapt mode of delivery, funding, etc., even several years after introduction. Thank you very much. Scott?
Thank you, Carol, and thank you again to Kate and Debbie. This has been a very rich set of data that you've presented and some really gripping stories from countries' experiences in terms of what they have found that has worked well and what they are continuing to struggle with going forward. We've had a very engaged conversation from the participants by submitting the questions through the chat room, and we've been capturing those here in our notes, and we'll now proceed to this discussion section of the webinar. We're going to take the questions according to themes as they've been presented, and where we've had some questions come in that are actually asking about new data that we did not present but that have been a part of the project. And we'll get to those questions as well. So in the first instance, we had a group of questions related to communications and acceptability and the social mobilization efforts that have been done. And these questions are largely directed toward Kate, so I'll have you make a first crack at it, Kate. But there have also been some implications in the country examples that Carol has mentioned for many of these questions about social mobilization and communications. So Kate, in the first instance, a couple of questions to you. The first is around hesitancy. There were some concerns about why private schools or private school students, or even why health workers might have hesitated in accepting the vaccine or delivering the vaccine. Kate, would you be able to give us some examples from the data where this has occurred and what were some of the reasons for it?
Thanks, Scott. I think for private schools, this was a relatively widespread problem where, as Debbie mentioned, there was suspicion over government initiatives and parents felt they hadn't been given enough information or warned early enough that this program was going to go ahead. And I think that was compounded potentially by a less extensive social mobilization strategy. So the general community at large hadn't been mobilized widely enough at the beginning, and so that those messages hadn't filtered down to private schools. There was also a request in a number of countries by parents of girls at private schools where the school themselves should communicate to them individually or set up specific meetings And there was a general request for more information and guidance from the school directors as to what their policy was around general vaccine school health programs. In terms of the health workers, this was only a problem in a few countries, and it stemmed as a problem where parents went to doctors for advice before accepting for their child to be vaccinated. So this is where maybe healthcare seeking behavior is slightly higher, and doctors are seen, pediatricians or family health doctors are seen as a good resource for advice, but weren't necessarily mobilized by the government or the Ministry of Health about the program. So they hadn't heard about it. They often hesitated to recommend the vaccine, and this created hesitancy within the parents. So in those situations, greater mobilization of health workers is also needed about the program.
Thank you, Kate. Sticking on with the theme of communications, 2 more questions have arisen from the participants, and they relate to the community acceptability in specific groups or populations. The first one, Kate, is what were some of the strategies used to provide messages to girls who are not in school or who are hard to reach? How did countries identify them in the first instance? How did they get their families engaged? And in the same theme, given that HPV vaccine in some of these pilots was only given in a certain area, were there any concerns or complications by having the vaccine either only target girls or just be available in one area of the country, and whether or not there was any community hesitation or community reaction for that, for girls-only vaccinations or for vaccinations being given there but not elsewhere in the country? Any experience from the data on those 2 themes?
Okay, great questions. For out-of-school girls, identification was difficult, and that was raised as an issue by many countries. They are a relatively small proportion of the population. I think in all but 4 of our countries in our study, school enrollment is over 80%. So they were generally identified using community health workers or local social workers or volunteers within the community who were involved with local NGOs and knew these communities well. In terms of mobilization strategies for them, many countries opted to send representatives house to house, and this proved in the enumeration phase as very expensive unless those people were volunteers and already employed under another program. Other ways of mobilizing were through general community mobilization, but targeting events at potentially isolated communities or communities where it was known that school enrollment was lower. In terms of problems to do with demonstration projects only being in a certain area or programs in general targeting girls, the geographical restriction was an issue in 2 ways. In a few countries, national mobilization caused problems because communities asked why they weren't benefiting from the vaccine, and it had to be clearly explained that the government was piloting rollout and that they aimed to scale up nationally, but they were testing out delivery strategies. But it did raise issues of equity. And some countries, for that reason, decided not to use national communication channels, but only direct communication through local newspapers or local radio stations. Only targeting girls was not as big an issue as potentially might be expected. It was raised in a few countries that boys also wanted the vaccine. It was not raised particularly in a negative way, apart from the association with rumors around fertility. But generally, it was seen as, why are you withholding this benefit from our boys? And that was easily responded to with the link with cervical cancer. So I think I'll stop there, and if there are any further questions, we can involve more further.
Thank you, Kate. We're going to move on to a couple of other themes that are coming up in the questions from the participants. And there's a big theme around integration that has come up. And I'm going to actually ask all of our speakers to try to address these common questions. Around integration, the questions have been themed related to what integration was done, if any, or what opportunities are there to integrate, given what we know now about the delivery strategies that countries are doing or have done. Has there been any evaluation on whether or not integration in and of itself has helped countries to achieve higher coverage? And if so, what are the examples of that? And then finally, what would be your advice to countries and to partners supporting those countries of how they could use integration as a platform for delivery of further health services to adolescents? Maybe on this theme of integration, I'll ask Debbie to start us off, followed by Kate, and then followed by Carol, if you could, please.
Okay, thank you, Scott. So first of all, I think I want to go to an experience that I think the countries have to go through in order to assess this. One of the findings was that I think many countries are not fully aware of what is going on in terms of integration, and I'm going to discuss first of all adolescent health initiatives. The obvious statement is we will integrate this vaccine with other health initiatives that are going on in schools or are targeted to this age group. And that, I think, is a sensible starting point, but it's going to be incredibly important for countries to understand what is going on. What we saw was that countries have a number of listed activities for adolescent health, and I'm including the younger girls of 9 and 10 in this, and school-based health programs. But in reality, a number of these programs just are not being delivered, or they're not being delivered comprehensively across a country. So latching on to a program that you think may be being delivered, only to find that in fact it only happens in a couple of districts, is not really going to help. So you need to understand what is going on, and the stakeholder activities for this are not to be underestimated. It is actually quite difficult to establish what vertically driven programs, deworming could be one, there are various others, tetanus vaccination, how they're being given, how often, and how successfully. And data on these programs in some countries are actually lacking, so it's very difficult to know if this is an integrative activity that you want to back onto, or whether you want to take Scott's last point, which is to say, let's make HPV vaccination the initial activity and integrate and regalvanize other interventions with HPV vaccination. It can go both ways. On the whole, it was very difficult for us to assess from the work that we did how comprehensive the assessment of integration was. It wasn't required for some of the demonstration projects, and it only really came in as part of a requirement for the Gavi demonstration projects in terms of countries being asked in year 1 to assess opportunities for integration and perhaps testing it in year 2. And I'll leave Kate to comment on how well that went with the countries that tried it. What I think we saw was that it can be very challenging for countries to do this assessment. You're working with another group of stakeholders again. It doesn't mean it shouldn't be done, but they need to plan for this and really look at the programs carefully. I think it's really important to think about it in the direction I just mentioned, which is that if HPV vaccination can be rolled out very successfully through a variety of means to this target age group, and you have weaker adolescent health or school health projects that are being driven in a certain way in certain parts of the country but not well in other places, whether HPV vaccination can in fact be the opportunity to re-galvanize those health interventions. But you will always face a challenge, I think, where those programs are vertically delivered with different funding agencies. And that needs a lot of coordination, and it's already been, I think, quite challenging for countries to think about this in terms of coordinating Ministry of Health, Ministry of Education activities for HPV vaccination. Nevertheless, I think it's an important opportunity for sustainability, and WHO particularly stressed this in their initial highlighted paper on this area, in that this needs to be looked at, because otherwise you're duplicating effort. And it makes the routine delivery much more achievable if it's routine delivery with outreach that schools and other venues that are going to happen anyway. So if that's okay, I'm going to stop there, Scott, and hand over to Kate to give us the examples of how well this worked in the countries that attempted it and what they actually did.
Thanks, Debbie. I think it's unfortunate, but we only gathered 6 coverage estimates of experiences that tried joint delivery or integrated delivery. And this was largely because although countries may have planned to do it, they then were restricted in resources or couldn't identify another intervention to kind of latch onto. So amongst those 6 coverage estimates, they were very variable, similarly to the experiences that only delivered HPV vaccine. There was one experience I can think of that actually the reason for their low coverage was due to the priority on the ground being the co-intervention. So the health workers themselves thought of the joint intervention as the main priority and HPV as an add-on, and this reduced the emphasis on HPV, and our key informants said led to their lower coverage. The rest of the other 5 estimates were very variable. Some of them gained very good coverage, but it was unclear. There was very little detailed evaluation as to, for example, what the existing programs, what kind of target populations they actually accessed anyway, and whether HPV vaccine increased their coverage, or conversely, whether they could have got better HPV coverage without the joint intervention. So I think this is really an area that needs a lot more evaluation. I would second Debbie's points about the fact that it's very difficult to identify an intervention to join HPV on to, and where it worked well seemed to be where there were existing school health programs in place anyway. It was generally seen as easier to organize, and in a couple of cases, HPV vaccine could be added to an existing school health program consent form, and this really simplified the whole process. But this is rare, as I'm sure many people understand. So I think I'll hand back to Scott and Carol now.
And Carol, for you specifically, there's been some questions related to the school health program. You mentioned a couple of country examples where they actually had that program. And the questions are really around how long has that program been there? You gave one example from Sub-Saharan Africa and South Africa in terms of their school health program. And does the length and the stability of the program impact how well you can integrate HPV onto it? Or what services are viable through that mechanism, and maybe what services may not be viable through using a school health program? So a lot of dynamics there around the experience of having school health already be strong, or where it's weak, how can HPV, if it can, strengthen that? Could you talk a little bit further from your country examples from Chile, from South Africa, around specifically leveraging school health programs?
Thank you, Scott. Yes, I mentioned really South Africa. In fact, Madagascar also tried, but I will first talk about South Africa. And as Daisy mentioned, high-income, let's say high-income country, and South Africa is more and less high-income, they have a strong school health program, and they are already conducted activity in the school. And adding HPV to the program, which is already there, and adding the HPV program is an additional intervention that they are adding to the program. The program is already there, delivering some intervention. And also, I spoke about the puberty book that they have decided to add HPV vaccination at this program. So it's not easy. When we discussed with the API manager, she said it's not easy. It's still expensive, but South Africa has a budget for that, and they have funding to do that, and they decided to go ahead. For the other country in the region, and I know many countries in the region try to do it, during the demo project, they all conduct adolescent health intervention assessment to look at which intervention can be integrated to the HPV program. I talked about Madagascar. Madagascar did an integration, but it was not a real integration since they didn't do a combined intervention. They did the adolescent health intervention right after the vaccination. So it was not really an integrated approach. My feeling is, this is my own view, is I think the country who have already some intervention, like in school, like TT delivered at school, or maybe pregnancy, they can use, if the program is strong enough, and we have some countries in the region who are doing that, is to add the HPV vaccine delivery to a program already ongoing. This will really, I think, decrease maybe the funding burden that the country might face, because the problem is it's two vertical programs, and because these programs are not well coordinated and they are not working together, we are duplicating effort. But if a program exists already, the country should build on that and maybe add HPV vaccination to a program already existing. Over.
Thank you, Carol.
Scott, I wonder if I could just answer one last part of our question, because I think one of your questioners asked about examples. We can give you a few examples of what was tried, if that's going to be helpful, I think. Just so you can see the range that countries attempted to try with integration.
Yes, Debbie, please do.
So, as Kate has mentioned, we really had quite limited experiences reported back to us. I mean, Carol has highlighted at least some key ones. The kind of interventions that were attempted with integration included the ones we've already mentioned, so tetanus toxoid, oral polio vaccine. A child day outreach was attempted with HPV vaccination, and HPV was also integrated in a couple of countries with deworming and vitamin A supplementation, reproductive health kind of initiatives, hygiene and screening, hepatitis B vaccination, integration within the school health generic program, and there was a couple of countries that had that, and a mother and daughters program. And then a number of countries talked about what they might do, and that included those particular initiatives, but also child annual health checks and male circumcision, hygiene education and eye screening. But I think an important point was that these interventions are not always delivered to the same age group, and that didn't seem to matter. It's the fact that you are saving, as Carol mentioned, by going into the school to deliver something, and you can deliver that to two different age groups or two different classes. So it wasn't that the class that was getting, or the age group that was getting the HPV vaccination also got all of this. In some cases, they did get the other intervention, But in other occasions, the vaccine, say the oral polio vaccine or another vaccine, was targeted to a different age group. And I think that's important. One can be quite flexible. The main issues are, how often those initiatives happen. One particular country tried several different integrations depending which dose it was. So they would integrate one dose with one of the other interventions I've mentioned, and then the second dose was integrated with a second intervention. I'll stop there. Thank you, Scott.
Thank you, Debbie, for that further information. I think the participants really appreciate the direct examples that you have been given. Much to think about. As we conclude this webinar, there is a final question that we have time for, and advanced apologies for not getting to all of your questions, but we note that a recording of the webinar as well as a list of the questions will be available after, and you could always email the speakers whose contact details are on your slide if you want further information or specific answers to that specific questions. You can also go to the website www.rho.org/HPV-lessons, where all of the information from this original study has already been made available in multiple languages. There's a final thought from the participants, and I'd throw the question starting with Carol, and then maybe have Debbie and Kate chime in, and that is, there's been a lot of lessons learned. There's a lot of information from these findings. What ways are being done to ensure that these findings not just get to countries, but are used by countries to improve HPV vaccine delivery? What advice do you have in terms of how do you translate now the research evidence and the lessons learned to actual programs and the improvement of those programs? Carol, since you've been working most intimately with these countries, what's your advice of how we as partners or we as program managers or people working on the ground with countries can take these lessons forward and integrate them into their program?
Thank you, Scott. One thing we are really promoting, at least at the region, we have more than 20 countries now. We have either conducted demo projects or nationwide introduction. And for the new country is really to have experience shared, what you just said, lesson learned, but also from one country to the other to support one API manager going to the other one, and we saw that when we have meetings, when they are sharing experience, saying that you need to do that, and really sharing experience from one country, but one thing is to say is you cannot have one example for all countries. Each country is different from the other one, and each country has to take his own opportunities, but also his own constraints, and to build on that. We have now enough experience of demo projects and so on, and really is really to move to scale up, but to really assist the country for each of the components. Some of them we discussed about that today, but there are others, and to really assist them to scale up. It's not something which is difficult, but they have to be prepared in advance. They have to start preparation, and they have to be assisted. They have to be really supported. Over.
And Debbie, final thoughts from you as the leader of this research study. How would you advise countries going forward in terms of taking these lessons and really integrating them into their HPV program planning?
So I think one of the issues we face is, first of all, we're trying, as you know, to disseminate these as far as we can and to make people aware of the website. As Carol has mentioned, I think face-to-face interactions are absolutely critical here, because brainstorming is often what countries need. So as well as having the kind of the dissemination through meetings and this webinar and the website, the exchange of experiences is very important. So Carol again just mentioned this, that EPI managers who've done it, go to meetings where they can share the experiences with EPI managers that haven't done it, appreciating the specific country context. So at the country level, it's basically making aware of what is out there and showing people how they might expedite and change the way they do it. And then for ourselves, we are obviously making ourselves available to help with some of these activities, including workshops where it's applicable. We're attending as many as we can. At the sort of policy end, I think it's also important that we make the policy makers and the funders of these policies aware of the findings. So we are trying to work closely with the key global influencers like WHO and Gavi and the funders of the programs to take the results out there and then to engage with them in how they might make the funding opportunities and the support opportunities more appropriate to the lessons that have been learned. And I think that that is an area where we engaged very early on, and I think that this is important so that they themselves can encourage countries when they are thinking about their programs to have a workshop, perhaps to attend some central training opportunity, be it a workshop or when they are applying for the support for the national programs, an opportunity where ideas and can be exchanged and lessons learned can be summarized to them through the agency. And that way we hope that the future program planning can be a bit more facilitated and that countries don't have to repeat some of the issues and pitfalls that we've already seen. I think many of these are avoidable actually. They can still have an individual set of experiences, but they can perhaps take into consideration some of the points early on through a chance of hearing about these at the planning stage. I'll stop there. Thank you.
Thank you so much. And thank you to all of the speakers, Dr. Debbie Watson-Jones, Dr. Carol Tevye-Benison, and Kate Gallagher, for your contributions to this webinar. Thank you to the participants for joining in and hearing of these findings. We again highlight there on the screen the website where you can go to get all the documentation that has been made available from this project. The updated data will be posted shortly as well, so you will have both two sets of information in which to go forward with. We appreciate your time today. We hope that the information that's been shared has been useful to the work that you do and the work that you do supporting countries in this effort. We thank you again, and we'll be signing off now at this time. Thanks to everybody, and have a good day.